Honorable teachers and learned audience, Assalamu alaikum. So the topic is how do we establish standard cardiopulmonary bypass? So all complexities related to minimal invasive surgeries or aortic surgeries have been left out of this presentation. And by this we mean the way we do CPB in standard median sternotomy. So before going to CPB, we need to check a few things, like if the aorta is heavily calcified, whether you can do cannulation or a cross clamp at all. Then if there is a presence of PLSVC, because we need to have a very quiet, bloodless field. In the event we have a PLSVC, we will not have that. We have to put another sucker in the coronary sinus, or we have to cannulate the PLSVC or something of the sort. Then if there are other anomaly, venous drainage, or if there is aortic regurgitation, the cardioplegia, we are going to put in whether it is going to go into the coronaries or going to go back into the LV cavity. If there is a patent ductus arteriosus, then there is another way that the perfuse that we are going to perfuse through the aorta is going to come back to the heart, and whether there are any systemic pulmonary shunts. So before the preparation for CAB, the patient must be heparinized. We need to heparinize him in order to get a ACT more than 450, but we can actually take the purse string while the ACT is around 300. After that, what do? We ask the perfusionist to recirculate a closed tube in order to make sure that the perfusate is warm and the lines are all air-free. Okay. After that, we divide the lines and clamp at the patient's end and also at the machine end. Okay. Then we go for aortic cannulation. So for aortic cannulation, I'm going to go to the picture on the next slide and then come back here. So how do we do an aortic cannulation? We choose a site on the ventral aorta. However, you will see that another site is shown here, which is actually on the side. How do I get the cursor to work on the screen? Okay, so this is actually for when we do a cannulation through a thoracotomy. Okay, after that, what do? We take two standard, that is, we take two purse strings, two opposing purse strings. Although in this picture, we see that the ends of both the purse strings are on the assistant side, but commonly one end, which is the inner purse string, the end comes out on the assistant side, while the outer purse string, the end comes out to the surgeon side. Then we divide, no, we don't divide, we actually clear the adventitia within the boundary of this purse string. So as for myself, I don't totally clear it, I just make it a flap so that I can hold on to it and steady the aorta while I insert my cannula. Okay, so after that, we go for cannulation. So this is the method where they incised with an 11 blade, pressed with the finger, and then inserted the cannula. But however, there are other ways. One of it is actually you can grab the adventitial flap that you made, you cut it like a U on this side, but keep it intact on the upper side, and then you grab it with the DeBakey forceps, pull it down towards the leg so that the blood doesn't escape. And just as soon the moment you insert your cannula, you just let the aperture open for a brief period. And then you insert the cannula. After that, you tie down the snuggers on both sides, and then usually we do two encircling ties with the cannula, and on the flanges we have the snugger tubes. So after the cannulation, the cannula is filled retrogradely to the top. We let the air from the aorta, the blood from the aorta, to come to the top of the cannula. The principle is actually we can't let any air pass into the extracorporeal circulation. So after that, the arterial lines are connected to the cannula, but before that, we ask the perfusionist to forward the arterial line, and while actually it's forwarding, and the perfusate is filling up the cannula, sort of overspilling it, we connect it to it. So after the connection, we just ask him to stop the clamp, stop the pump, and then we take out the clamp on the aortic cannula and ask him to check how the swing is, whether the cannula has passed actually into the lumen of the aorta. Okay, so what are the complications of root cannulation? Inability to introduce the cannula. For instance, if we didn't do the adventitial clearing, there is a chance you are actually pressing the adventitia in the interior of the aorta and couldn't get the cannula into the true lumen of the aorta. Then there is inadequate incision. If there is a plugged site on the aorta where exactly you're cannulating into, you may actually dislodge that plug and send it to the cerebral circulation. Then there is intramural placement of the cannula, which means that the cannula is actually passing through the layers of the aorta, then embolization of atheromatous plaque, air embolism, persistent bleeding around the cannula, or malposition of the tip towards the opposite side into the aortic valve, or the cannula tip has actually gone into one of the arch vessels. These sort of things happen when you have an EOPA cannula and you can actually pass it a considerable length inside the aorta. Then there's the chance of dissection of the aorta, or kinking in the circuit, or inadequate size cannula. You have taken a very small cannula with respect to the body surface area of the patient, and actually you can't maintain a good circulation with it. And aneurysm formation at the cannula site. Okay, next we go for the venous cannulation. Depending upon the type of surgery, whether you need to open the right heart or not, you can do two things. You can do selective bicaval cannulation. You can do a single one-stage cavoatrial cannulation. So on the left side, we see this picture here. Please ignore this thing. This is actually cavoatrial cannulation. They pass the cannulas through the right auricle all the way into the inferior vena cava. And this is, and we have another cannulation. This is selective superior vena cava and inferior vena cava cannulation. So then we need to do the snaring, because if we don't do the snaring, or another term, it is also called tourniqueting. So we need to tourniquet the wall of the vessel, the vena cava, around the cannula so that blood doesn't escape into the cavity or air is not entrained into the cannula. So this is how we snare. This is an investing pericardium on the medial side of the superior vena cava that we make a nick onto, then we pass a snaring tape. Similar thing goes for on the left side. Here it's above the right pulmonary artery, and this is below the right pulmonary vein here. We do the snaring. So after what are the complications? Just like complications in aortic cannulation, there are also complications in venous complications. Like if you press too much on the heart while doing this cannulation, you may be indiscriminately pressing on the right atrium too much, and you won't be able to do good cannulation, or the patient goes into a hemodynamic instability because of that. And there are also other problems like the cannula going into lots of wrong places like the azygos vein or to the hepatic veins, or even to the left atrium.
2 minutes only.
Okay, so cardioplegia, you can do antegrade or retrograde. Let's go to the prime volume. This is the way we consider the prime volume. We need to consider that we need to do 24% hematocrit while the patient is on pump. So this is the way we calculate the prime volume. Then the aortic cross-clamping. We ask the perfusionist to reduce the pump flow and apply the cross clamp. Then the pump flow is restarted, and we immediately start the root cardioplegia delivery with a pressure of 60 to 90 millimeter of mercury. This is in case of a closed aortic root, but we can do selective cardioplegia as well in aortic valve surgeries, which Professor Farooq sir will describe to you later. In those cases, we can do selectively cannulate, and we can even do retrograde cardioplegia after doing an antegrade cardioplegia for aortic valve surgery so that it doesn't mess with our work. Okay, so after that, I need to tell you about what do we do in cardiotomy. We do cardiotomy suction. I have seen assistants continuously shouting at the perfusionist, blue up, red up, blue up, red up. But always remember, cardiotomy suction at high negative pressures isn't good, because you're doing an interface, you're creating an air-blood interface, and if you suck too heavily on that, you're going to hemolyze this blood. So after that, you finish your surgery, you close your heart, then there are rewarming, which is more dangerous than cooling, because you see, if you put a bottle of Coke outside, what do we see in the heat? Or once you open it up, it fizzes up. So that means that The lower the temperature, the gases would be more soluble in it.
Yeah. Thank you, Dr. Tanveer.
Thank you.
So
So
thank you so much
there is
for
just one
elaborate
slide,
discussion.
removal of the clamp and weaning from cardiopulmonary bypass.
Yeah.
Thank you.
Thank you so much, Dr. Tanveer.